Today, the unprecedented nature of the pandemic seems to offer a major opportunity for us to rethink the ways in which we connect, share, and use data resources as we plan for health system design and policy in a post-COVID age. So if I can, I'd like to start the conversation with you, Mirit, because, you know, on behalf of one of the world's largest stewards of scientific data, I'm curious to know what the crisis has actually meant for Elsevier in terms of new approaches and innovation in this space of data utilization. And of course, this could draw to a degree on some of the experiences you've already had with past pandemics. I think we're most interested to hear what's really been happening on the ground in terms of your response to COVID.
Thank you. Yes, it's been unprecedented, of course, right? So Elsevier, as a publisher, as a company whose mission is to advance science and health, we've been very exposed to the emerging research, actually in the very early days, already in January coming out of China. And really what we started doing pretty much immediately is accelerate the publication of this content, put it up. We've set up a coronavirus information center back in January, and we've put all the research that we got on there since those early days. And the main challenge in the early days was really around the quantity and being able to process the data the research and the data quickly enough to be able to put it out there. So we had to increase our capacity. We offered Chinese language services because in the early days it all came from China, all the research, and we accelerated as much as we could, making it public. We've set up this information center early days. Today we have 31,000 articles, coronavirus article there. Of course, also from previous versions of the coronavirus, but yeah, 31,000. And we had 60 million downloads. So it's really...
Sorry, just to clarify, was that 16 or 60?
60.
60, okay, 60 million. Okay.
We've never experienced anything like this, right? So what we had to build was the capacity and the foundation to be able to accommodate this, right? And then in March and April, we started parsing the data. So we now have an information center for healthcare professionals with care plans, patient handouts, drug monographs, again, everything around coronavirus. We've put even skills and manuals because all these retired nurses who came back to practice needed access to information on how to deal with the coronavirus. And then I think our latest one is the research one, where we've also started offering research tools to be able to store and share data directly more effectively. We've also allowed machine learning on our databases, and what else, and collaboration tools. So to me, long answer, to me, this has been a real test case of open science, right? And the role that we can play there. Of course, all of what I just mentioned, we're offering for free. But really the principles of increasing visibility, enabling collaboration, enabling data sharing, and data reproducibility, right? So doing it in a way that experiments can be refined and repeated, fostering collaboration. And we've seen a lot of collaboration these days, I'm sure everybody has, between public and private sectors, pharma companies and academia. And that's really something that we're very supportive of and have been trying to help facilitate as well. And I would say another thing we've seen a lot of is interdisciplinary research. So it's not, so it's really cutting across. And I mean, personally, I've been contacted by one research group that was looking to do vocal recognition to help diagnosis. So based on your voice, whether your lungs are affected. So the expertise they were looking for was not just medical, right? They were looking for engineering resources as well. So really very interesting times. There's a lot we can do with data and that we have been doing with data. You asked me about innovation. So one of the things we've done, because of the huge volume of submissions that we've seen, we've developed an algorithm to help us identify COVID-19 research so that we could get this peer reviewed earlier than you know, jump the queue in a way.
Right. Well, it sounds like a pretty...
Some examples of what we've encountered. So
yeah, it's a pretty comprehensive portfolio. I'm sure it keeps you quite busy as the head of strategy. I mean, Xosé, I mean, obviously, Institut Curie, I mean, you haven't had the same strategic positioning as, say, Pasteur in terms of the actual clinical research around the coronavirus. But looking at, you know, sort of the broader health life sciences community, are you seeing a change in the mindset around data sharing, utilization, and people looking to embrace a new approach?
Hi, good afternoon, Simon. Yes, I mean, this crisis has given us a great opportunity to have a glimpse on what the future is about. It's about digital being central in any strategy. You know, Mirit just mentioned some examples. At Curie, you know, obviously we having a hospital group in Paris. Paris has been pretty strongly hit by this crisis. We had to adapt how to handle cancer patients, how to handle cancer patients COVID positive, and how to handle the hospital so we could offer spare capacity to the region. So we had to develop, from the logistics point of view, different circuits across the hospital, and that was a challenge for our physicians and for the managers of these hospitals. But also at our research center, not being Pasteur, being Curie, we were also involved in fundamental research in terms of replication of viruses. We are involved in a number of clinical trials, because again, during this crisis, there was the importance of being able to discriminate between fake news and real news, the capacity, and you know, that will touch on the tools that Elsevier have been developing, how you can, you know, reassess the pre-publication status of some of the research which were proven wrong afterwards. So there was a number of challenges to revisit how we work, and definitely one of the big spaces is in this digital needs data, open ways of sharing data. And you know, one of your speakers this morning talked about the increased number of teleconsultations in hospitals. That's something pretty new in France, that going from 40,000 to over 500,000 teleconsultations over that a very short period, over a month. That's dramatic in terms of the impact. And obviously, everybody's working on Zoom, on Teams, on WebEx. If you see the capacity, you know, the Teams guys delivered today in one day what they delivered in 2019. That shows you how cloud solutions and being able to scale up has been dramatically changed during this time.
So I think that's actually a great link, because if we think about the cloud solutions in particular, I mean, obviously that happens at the organizational level, but you know, at the macro level, one of the big shining projects from the European Commission has been the establishment of a COVID-19 data platform, which is gathering vast amounts of population health data sets, national sets, regional sets, etc. This is sort of being linked in with the development of the Open Science Cloud as sort of the federating structure for science in Europe going forward. But I guess the question to both of you is do you think this is this actually a new model for open science that we're seeing being developed in real time thanks to the crisis, or are these approaches sort of short-term fixes to a very specific crisis? Are we on the edge of a new era of open science, do you think? Mirit, would you like to go first?
So I want to say yes. I think this was a real test case, right? To whether the principles of open science can work, and I think they work great. I think that, you know, some of what I described before has, you know, the interdisciplinarity and the collaboration are part of the reason that we are moving quite quickly forward in terms of our knowledge about the disease and what we can do about it, diagnosis, the types of it. So all of this, so to me, it's been an accelerator. We were able to test a lot of these principles that we've been talking about for a while and actually see the value of them. So I would hope that we as a community would find a way to continue and do more research in this way. Sharing data early, collaborating across countries and across sectors. I see a lot of good things that came out of this. which I hope are sustainable. And certainly where I am at Elsevier, we think that's a very positive thing for science, which we would like to continue and support going forward.
Super. Would you echo that, Xosé? I mean, and also, I guess a related question is, you know, this has been applied in the specific context of a pandemic or coronavirus. Is it applicable across a broader spectrum of health and life sciences, oncology, for example?
I would hope so. I would hope that we don't go back to the old ways. But you know, this weekend we celebrated the 20th anniversary of the first draft of the human genome. And 20 years ago, we were talking about how that was going to dramatically change medicine, how, you know, 20 years afterwards has been changed, but the clinical space is pretty conservative and things take time. So yes, I hope that we won't be going back to the old ways, but there are things you can do in an emergency that you cannot do on a routine. So yes, there will be new ways of working. There will be, you know, these new technologies are here. People experience them. You know, teleworking. That was something which, in some spaces, you know, France is complicated sometimes in this situation, and has been adopted and it works. And if you prove that things work, people would say, well, you know, why going back to the old ways if we can also get the best of both worlds? So I would hope that that's going to be the answer. But the clinical space is not going to be overnight. Things will be gradual.
So that, for me, that raises quite an interesting related question, which is that obviously if we have new principles or principles which are being tested and now proven to work, at the development of new platforms or instruments to accelerate the flow of data between different parts of the research landscape, it needs to happen within a context, within some kind of established framework and governance mechanisms. So what does that look like for you going forward? I mean, how do we ensure that the governance of open science, and in particular, the way that we govern data and its use, is properly inclusive going forward? I mean, perhaps Europe has a bit of a legacy of sort of technical top-down approaches, the very broad frameworks that Mark Pearson talked about this morning. If it's really a new era, should we rethink the way that we design and govern these approaches as well? Mirit, would you like to take that first?
Should we redesign? So for data sharing collaboration to work, we do need to have the right systems and processes in place, right? And we have to govern that. And I know we have been, all of us, around the ecosystem, right? Have been doing a lot. The EU has been doing a lot. We have the FAIR principles in place, but yes, there's more we need to do, and especially if we want to apply more innovative technologies, AI, to data, we need to get the data to a better state, right? And we talk about sharing data across the EU. Even doing it across a region is difficult today, across settings, primary, secondary, and tertiary, right? So for us to really be able to do more with medical data, especially, yes, there's more we need to do around the infrastructure. And I think everybody has a role to play. Health authorities, private bodies can help with the processes and the governance, and we all have to think about privacy and the identification, but still, can we actually create longitudinal data sets to allow us to do more, to predict more, to segment patients and deliver effective healthcare? And we've seen some of this happen in the current climate, a lot more use of real world evidence to progress more quickly. As Xosé said, to apply it long term, there are many obstacles we need to overcome. And we all have to come together, I feel, to make this happen.
So Xosé, I mean, linking to that, obviously that we've got another range of big projects coming our way through the European cycle, including the health data space, or the common data spaces, but one particular dedicated space. The cloud, the digital strategy to boost Europe's capacity, cloud computing, network technologies, and so forth. I mean, what's your take on the infrastructure environment at the moment? Are we properly set up to achieve what Mirit is talking about in terms of this greater flow and use of relevant data and information?
We have a few tools within reach. You know, you mentioned top down, bottom up. You know, there is a bottom up initiative right now, which is the Lifetime Initiative, which it's a group of 90 academic organizations and 80 industrial partners, creating a space, a European space, to harness the complexity of disease. Obviously, this is a project which is coordinated between Institut Curie and the Max Delbruck Center for Molecular Medicine. There are a number of diseases, obviously cancer is one of them, but it's trying to move forward the precision medicine paradigm, which today it's pretty successful in the oncology space, to other diseases. And that's a bottom-up organization because we have a number of, you know, it's across 17 European countries, I think, but there are new countries joining this initiative. That's on one space where we want to combine artificial intelligence to be able to predict, to create models that will enable us to intersect disease. So be able to find ways of treating disease before disease is diagnosed in individuals. That's on one space. And then we have, you know, at the end of the year, early next year, we'll have the cancer mission, which again, within the cancer space, should give us a framework and which are the big priorities. And, you know, this mission, it is like, you know, we can think of the US in the late 60s when Kennedy wanted to put man on the moon. And these missions are defined like in this way, very clear. You know, Professor Mazzucato in London has been working with the Commission to define clearly these missions in a way that they are ambitious, well-defined, and achievable. And the idea is to reduce mortality in cancer. So, you know, combining these kind of approaches, the academic approaches where you will get the new tools, single-cell sequencing, artificial intelligence to predict disease. And then you have a framework which enables you to tackle one of these diseases. Obviously, there will be other missions in other spaces. I know well the cancer space. These are two initiatives which, at a European level, should help pushing this European way of doing things, and you know, help us bring other spaces together with us. That's a couple.
I think that's a great link, because I mean, obviously, the final panel in today's conference is going to look more explicitly at the questions of AI in health. And I think, you know, from very different perspectives, your organizations have both been pretty much at the front of developing new solutions and so on. So there's a broader question about AI as part of the future European data strategy, industrial strategy, et cetera, et cetera. We've talked also earlier about the potential of AI to unlock the full potential of data, and not just new data, but also its application to legacy data sets, which, okay, may not be all interoperable, but they're high quality, and there's a vast amount of information that could be used as a fuel for the development of new algorithms and new solutions. So, you know, from your perspective, is AI a kind of missing link at the moment, or an important bridge between the smart, healthy systems that we expect in the future? And how do you see its development and its evolution? What will be the real sort of headlines or milestones for the next 2, 3, 5 years in terms of AI in health?
Which one? Who goes first? Jose, do you go first?
Okay. Thanks, Mirit. Okay, you know, artificial intelligence is a set of tools, but it's not the answer to everything. You mentioned historical data. And we have comprehensive data collections. You know, I have the privilege of being the chief data officer on an organization like Institut Curie with clinical records. You know, hospitals were digitalized 20 years ago, and I have a follow-up of patients for over 20 years. So that's the perfect space to be able to understand cancer. And it's not only, and often people talk about volumes and the amount of data, and that's what is called, you know, you could say that is the AI fallacy. It's not about the amount, it's about the quality. You need to have quality data, and to have quality data, you need to annotate it. So, and that's very expensive and time consuming. Yes, you can argue that you could develop artificial intelligence tools which will enable you to clean the data, but to be able to clean the data, you need to know what you are looking for. and what kind of questions you will be answering with that data. So data capture, I mean, in the clinical space, data capture, when you are looking after patients, if you're using that data to do research, you need to take into account the context, and it's not always straightforward. So artificial intelligence is not the answer to everything. We have a number of projects in my team, and sometimes, you know, we compare a number of approaches, and turns out the traditional all inference statistical methods work better than the fancy random forest or the fancy artificial intelligence algorithm. So it's not all about machine learning or about artificial intelligence. It's about having the right tools to address those questions. But yes, artificial intelligence is here to stay, and there will be, not everything will be doable with artificial intelligence tools, but there are lots of artificial intelligence tools helping us to be able to analyze our data.
Mm.
Yeah.
Very good. I presume that actually plays quite nicely into what you'd like to say, Mirit.
I was just going to agree. Yes, data capture is hurdle number one. Then data cleansing and, you know, getting it out of silos and linking and all of that is problem number two. Technology can help us with both. And then when I think about data, there are two types, right? There's the research data, and that's where Elsevier, we already play a big role, right, in encouraging researchers to share their data, to put it in a data repository, you know, whichever one, right? As long as it's out and can be looked at by others, it's great. So one is the data capture and enabling that, encouraging that, and building repositories where that can happen. That's challenge number one. But then challenge number two around making the data searchable and link it and all of that is really where technology can help us a lot more.
Mm.
That's in research, but then in healthcare, it's another story, right, Jose? Because even the data capture is a lot harder with different EMR systems, etc., and different levels of readiness, even across the same country. And then the linking, you know, the cross settings, what I mentioned before, is very difficult. So I agree with Jose. You need to start with something more manageable. Define where you go. So for you, it's oncology, right? We also focus quite a lot on oncology, and use technology and AI there to start building, whether it's, you know, diagnosis tools or treatment algorithms, patient segmentations. Tools can play a big role there.
So I have one more question around the AI issue, and it kind of has two parts to it. The first is about capabilities. But so in other words, the skills and the knowledge that individual researchers or clinicians need to have in order to understand the potential and the application of these solutions to specific problems within their professional settings. And then the second is its value to patients. And do we need to somehow do an awful lot more in order to inform the broader public about the potential value or even the potential risks of AI within a future of healthcare, which is probably going to be a lot more personalized, with a lot more patient ownership of data and patients as generators of data? So whether or not you want to answer both or just pick one of them, the organizational capabilities, do we need a new approach to skills and learning within, or reskilling? And then second, on public education and awareness about the use of AI applications in health.
Edit.
Yeah, I'm thinking about where to start. Okay, so I think when it comes, you asked about clinicians, but I think when it comes to both researchers and clinicians, it's not necessarily that they need to do their job differently, but there are new types of data specialists that will probably have roles to play in the direction that we're going into, right? What we're trying to do, for example, for clinicians, is to build them tools which are not that different from the tools they use today, but rather than having to go and look up something, they get guidance of, based on what we see here, here's what a likely diagnosis would be, and here's what you would need to do to confirm it. So it's not that the clinician need to have different skills to use these different types of tools, but it's more to develop those, the data scientists or clinician scientists who who are developing these sort of tools, they need to have quite unique capabilities that we haven't seen before, which is not only look at the evidence, decide what's the best, but also be able to test it on large data sets. And I'll try to also answer quickly the second part and then hand over to Jose. So when it comes to the patient is at the center, and this patient, of course, in the health sphere owns their own data. So it has to be, you know, an opt-in model, and it's up to all of us to make sure that data is protected and de-identified and is only used in this way. And I think this is the setup where patients really benefit from, as you said, truly personalized medicine. Because if you could look not just at the type of cancer, but also, you know, everything else, biomarkers, gender, age, patient care will just be so much better.
I certainly hope so. I think that's certainly the ambition. Xosé, some last thoughts from you on this.
Quickly, yes. I mean, you know, when you are putting together a data strategy, you need a multidisciplinary team. You need to have physicians around the table, data scientists, data managers, and often the most exciting data projects come from questions outside the team. Somebody from the hospital say, you guys in the data department, you know, we have this question. Do you think that we will be able to? And those are the most exciting projects because you sit down with them, you understand what are the challenges, and then we put together the tools and we dive into the data. And obviously, everything we do at Curie is thinking of our patients. So we have data thanks to the consent, those patients' consent. You know, when we are working with cancer, the consent percentage is around 95, 97%. It is not other specialties where people might be more reluctant to say, yes, you can use my data for research. You know, if you try to look primary data GPs, people might be more reluctant because you can look into their life because, you know, every time you go to your GP, they have a follow-up of their life. People coming to a hospital, a cancer hospital like Curie, they know that when we ask them for permission to use the data, it's for research on oncology, and they know that that cancer affecting them may affect in the future the children or some of the relatives, and they are very well motivated. So in our cases, what we do, it's for our patients, and we thank them because they help us progressing and moving forward in this space of research in oncology and developing better ways of treating the patients. And patients understand that the way you treat patients today is based on the experience you have learned from the past. And that's the way medicine has been working since
millennia.
Hippocrates.
Okay, well, listen, I'm really sorry to say that our time is up. I think we could have carried this on for half an hour on a range of different topics, but the AI panel is waiting to take these conversations forward and look at some of the other dimensions of European strategy and the future of AI in health. But I would really like to thank you once again, Mirit and Xosé, for taking the time this afternoon and sharing your insights with us. Thank you again, and I will now hand over to David Pringle for the final session of the conference. So
thank you.